So in this one, looks like actions deeper in the dermis. It seems that there's kind of this diffuse dermal infiltrate. Seems like up top, relatively spared. Nothing much going on there.
Exactly.
Deeper process. I don't see any regularity.
Inflammatory or neoplastic mostly?
I'm thinking neoplastic.
Yeah, you're thinking right.
Hooray.
Can you tell anything about the things like a benign or malignant?
I think malignant kind of has these, varying zones of color change, and you got all these different shapes going on.
Yeah, you got this sort of diffuse pattern in the dermis of.
I guess people say like cords and tubules or something. So maybe.
Yeah, kind of cords,
ducts.
strands, little aggregations of cells. Good, excellent. So now, is that sort of characteristic of a primary or possibly a secondary cutaneous involvement?
I think with a relatively spared epidermis, I was thinking maybe secondary.
Yeah,
from somewhere else.
Like a met. Good. So, do you like epithelial or non-epithelial?
I think epithelial is.
Yeah, good. Epithelial,
good.
Excellent. And then the sort of gets harder, to determine if it's a metastasis, what is the primary source.
Yeah.
And you probably aren't going to be required to determine that, but this does have one characteristic feature that we see in this specific kind of metastatic lesion, this central necrosis.
Yeah.
So-called dirty necrosis. You know where you see that?
Is that ductal carcinoma?
No, it's actually most common in colon cancer.
Colon.
So this is a metastatic colon cancer. You probably wouldn't necessarily, again, they're not going to ask you a lot to, for that. But if you could pick out the fact that it's probably a metastatic lesion, it's an adenocarcinoma gland here. And here's that dirty central necrosis. It's a really nice example of that. So colon cancer doesn't, metastasize all that commonly, but it does. And we've got some clinical pictures. So again, when you see these sort of multiple nodules, nondescript, think about mets. These are usually kind of firm and kind of stony hard. Next slide. So just kind of an interesting variant of metastatic cancer. Next slide. Okay, good. Everybody got that right, huh? This one is fair games. The board very well asked you about this.
Okay, so here we have a shape of a kind of polyploid neoplasm.
Yeah, it might even be sessile. Kind of like it looks like it's kind of sticking up, though. You're exactly right.
See massive, kind of a lot of hyperkeratosis. It's like a possibly like an acral or volar surface.
Good, very good. Volar skin.
So you see them kind of going in, solid these uniform blue cells, like necrocerebral type.
So you think it's a inflammatory or neoplastic process?
I guess like inflammatory. I guess neoplastic.
Neoplastic,
benign.
good. And benign or malignant?
Benign.
Yeah, it's very symmetrical, very well circumscribed. You can actually see a little dell on both sides of this, like a little moat. Okay, and as we go to higher magnification, and so it's epithelial, benign. Now we need to decide what kind of epithelium, right? Any ideas?
So there's a lot of uniform blue cells. So it's kind of a hint, I feel like. And then there's also a whole bunch of ducts.
Yeah, there's a little duct maybe right there. It might be a blood vessel. It's probably a duct over there. But it's kind of a diffuse proliferation of these very monomorphous little basophilic cells. So what's the most likely diagnosis?
Poroma.
Yeah, equine poroma. It's a nice example of that. It's a beautiful example of that. Now, what's going on right here in those cells?
So, I didn't see which one.
Yeah, they have kind of an eosinophilic cytoplasm, a pycnotic nucleus, and then maybe a karyorectic nucleus over here. So it's just breaking apart. So what is that a sign of?
Possibly Carex of maybe further differentiation or.
Well, the cells are dying. So you get like some individually necrotic keratinocytes in this thing. And poroid lesions like poroma, poroided adenoma, they not uncommonly get little zones of necrosis in them. Usually when we think of necrosis, we think of malignant. But in the poroid lesions, it kind of breaks the rule a little bit. So just realize that can happen. It doesn't mean that it's malignant. So this one doesn't have any mitotic figures, but it does have a couple of necrotic keratinocytes. Yeah, there's a mitotic figure. Okay, see one right there? So you don't just, oh my God, this is porocarcinoma. It's got one mitotic figure. No, that doesn't change the diagnosis. Everything else is benign. You just remember you can get some of this necrosis in these lesions and occasionally in a mitotic figure or two. This is still just a totally benign lesion. We have a clinical photo. These often look like warts or pyogenic granulomas like this. You can see the nice little sort of delicate periphery, very characteristic. So these are totally benign lesions, and the differential includes the other poroid lesions. So we won't go through all of those this morning, but just so you know, they all kind of have the same cell type. So there's like 4 of them that you kind of have to know. Okay, very good.
Okay. So we have a punch biopsy. It looks like most of the action's in the dermis.
Okay.
There's a neoplasm in the deeper dermis, but superficial to that, it looks like there's a little bit of perivascular infiltrate. I think
So something going down here.
right. I think
Good.
we're looking at the process in the deep dermis.
Excellent.
It's pretty
Maybe even possibly even beneath the dermis.
right. It looks like in some sections it looks like it's getting to the sub-Q.
Yeah. Maybe even below that. Like here's some subcutaneous fat here, so maybe it's even beneath the subcutaneous fat.
Yeah. It looks like from here you could see that it's not very well demarcated. It's kind of, but it's spindle cells. It's composed of
Good.
spindle cells.
So epithelial or non-epithelial?
Non-epithelial.
Good, non-epithelial. Usually when it's spindle, favors non-epithelial. That doesn't have to be. You can get spindle cell squamous cell carcinoma, for example. But still, it favors, in most cases, it's going to be non-epithelial. Now, of those types of spindle cell lesions, which of those is the most common, or do you favor in this case?
Well, there's a differential for this, and maybe this one has a mixoid look to it, a bluish hue.
Good.
So I can see the bluish hue, and then probably like fibroblasts.
Yeah. These are kind of plump cells. They're not thin, delicate, S-shaped cells like you see with neural. There's also some collagen admixed in here. Pretty thick, ropey collagen down in this area. So yes, fibroblast. Fibroblast, maybe some histiocytes, so in that category. Did you like benign or malignant?
Benign.
Good, benign. So what's the most likely diagnosis?
Nodular fasciitis.
Yeah, or what's the nodular fasciitis, what kind of category does that fit into? What family of entities is nodular fasciitis part of?
Like the myofibroblast?
It is a myofibroblastic proliferation, you're right, but there's kind of a family of disorders that are in that same category of nodular fasciitis. Usually nodular fasciitis is more inflammatory with more myxoid stroma, it's looser, sometimes you get mitotic figures, it's also called pseudosarcomatous fasciitis. So this one really doesn't have quite that much mucin in it, and it's not all that proliferative at this stage. It's a little bit more chronic process here.
It's not well circumscribed to where I would think like a fibroma.
Yeah, now you're talking fibroma. What kind of fibroma specifically? This is deep, right? So maybe like fibroma of tendon sheath. So if it's in the fibroma, there's a family of entities called the fibromatoses, right?
Yes.
So this could be one of those. So nodular fasciitis, if you kind of leave it alone long enough, it might eventually turn into like a fibroma, maybe a fibroma of tendon sheath. If you get some of them giant cell tumor of tendon sheaths in that category, what else is in the family of the fibromatoses? Old guy, used to be a carpenter, hammered a lot. He's got a kind of a claw hand, and you look at him clinically, he's got this sort of
What is it? Dupuytren's?
yeah, Dupuytren's, the fibromatoses. So Dupuytren's, plantar fibromatosis, torticollis, Peyronie's disease, desmoid fibromatosis. So those are all in the same category family of these fibromatoses. They're benign proliferations of these fibroblasts and histiocytes. They're sort of almost, keloid. Some people throw that into that category a little bit. So they're disorders of the fibroblasts and myofibroblasts. So I think you got a couple of pictures. So this one was plantar fibromatosis. You wouldn't know that, but it could be palmar fibromatosis, which is due to fracture. So you should learn about those, just know what they are. They're totally benign. They usually have a very bland morphology to the cells, like you saw here. They can be a problem when they go deep, like if they're a desmoid tumor and they get into the brachial plexus or something like that. What syndrome is associated with desmoid fibromas?
Don't know.
Anybody know? Gardner's syndrome. So polyposis coli, cysts, desmoid fibromas, colon cancer. So desmoid and Gardner's. So that could be on the board. Because Gardner's does have cysts and does have a dermatologic manifestation of it. Okay. All right. Who wants to give this one a go?
Okay, we've got a punch from this view, a very dense infiltrate,
Right.
superficial and deep.
Yeah, it goes all the way to the fat.
Um,
What kind of cells are these?
they're very dark, so I'm right now favoring lymph,
Yeah, so what's the diagnosis?
sort of lymphoproliferative.
Okay, yeah, in the lymphoproliferative category. And you favor benign or malignant at this power? Yeah. First reflex, lymphoma. Does that look good? So we're going to go to higher magnification at the end of the day and see. So we say, well, it sure looks like a lymphoma low power. It goes to the fat. It's diffuse. It's not just top heavy. There's no wedge-shaped architecture to it. So, well, there are a few other things that might simulate a lymphoma. Let's make sure it's not Merkel cell or something like that. It's probably not going to be. Sometimes the anaplastic lymphomas can simulate Merkel and vice versa. But when you see this pattern, the immediate reflex is this is probably lymphoma. Then at higher magnification, let's see if we can talk ourselves out of it. Could it possibly be a pseudo-lymphoma? What do you think? Think it might be benign?
No.
Was that a yes or a no? I couldn't.
No.
A no, good, because it's not benign. It's sheets of these atypical cells. They're mitotic figures all over the place. Very atypical lymphoid cells. Lots of open chromatin. I have a kidney bean shape there. Convoluted cell up here. Okay, so is this more likely to be a T or B cell lymphoma?
I think a T cell.
T, good. Why?
Just the way that it's not organized.
Well, there's two main reasons. One is the cell morphology, so when the cells kind of look cerebriform and convoluted. And then there's also epidermal involvement.
No, epidermal.
Yeah. So what's the diagnosis here?
Sort of T cell lymphoma.
Yeah, any specific one that you'd kind of like to maybe throw the name out on?
Like
Got
CCL
epidermotropism.
or-
Yeah, this is mycosis fungoides, tumor stage. It still has some epidermotropism in here. Sometimes you get MF in the tumor stage, it loses the epidermotropism. Also loses the epidermotropism in Sézary syndrome. The other thing is that these subcutaneous T-cell lymphomas. When you get this involved in the fat like this, that's more commonly seen with T-cell lymphoma too. Doesn't have to be. You get B-cell lymphoma down in here also, but when you see this rimming, that favors T-cell lymphoma. So this was tumor stage mycosis fungoides. That's what it looked like clinically. So obviously not a good situation for the patient when they get that. So just remember, so this pattern is really great for lymphoma. So I'm not sure if the board would expect you to know this was MF, but they might sort of expect you to realize that all this epidermal tropism kind of favors that versus a B-cell lymphoma. B-cell lymphoma sometimes give you like a follicles, like follicle center cell lymphoma, so you don't see that in the T-cell lymphomas as common. All right, this one is a fantastic one.
So this is a punch biopsy. The stratum corneum is bright red and compacted, and then there's a papillary dermopattern, and there's some lymphocytic infiltration and inflammatosis below that, but it's not a thick blue band.
Yeah, it's pretty much very much gone away.
Yeah.
Good.
On higher magnification, I did notice there were some dilated superficial vessels within the dermis.
Okay.
So the two differentials that I was playing with were LSNA and radiation dermatitis. So because there wasn't that, because of the dilated vessels, I was thinking more radiation dermatitis. But if the inflammation is there and then it's gone, then it could still be LSNA.
Well, so we've got a quandary. I guess more of a dilemma, right? We have two things we have to deal with. Quandaries, multiple things.
So yeah, they look super similar, but they talk about the flag sign, which you're not really seeing that thick band here, but it could be burnt out. And then
what about this? What's going on here?
The stratum corneum is very compacted.
And is it normal thickness?
No, it's thick.
Yeah. And what's going on with the epidermis?
Oh, so they've been rubbing.
Yes. So what does that help?
LSNA.
So which of the two disorders tends to give you more pruritus?
LSNA.
Yeah, of course. Lichen sclerosus is very pretty. So what's interesting is you get, most of the time when you get lichen simplex chronicus, you get acanthosis and regular epidermal hyperplasia. With LSNA, because you've got the thinning of the epidermis, the atrophy, even though they rub it, you don't get the acanthosis. You just get the marked thickening of the cornified layer. And the other thing that you see with radiation dermatitis are bizarre, irregular fibroblasts. We really don't have any of those here. So this is a nice example of lichen sclerosus epitrophicus. So notice there's the sclerotic collagen. This is sclerosis of the papillary dermis. And then you get this edema also, that you pointed out. So these are all characteristic findings of LSNA. Now, is this an early or a kind of a later lesion of LSNA?
I would say later.
Yeah. What do you see in an early stage?
You see a really dense infiltrate.
Yeah, it can simulate lichen planus. And sometimes when it's pretty early, they don't have much sclerosis, and it's tough to, completely exclude it from lichen planus or, lichenoid vulvitis if it's in the groin area, something like that. So basically, when it gets at this stage, most of that infiltrate's gone away. So this is LSNA. Sometimes you get, what do you call it when you get sclerosis of the reticular dermis and this area?
Lichen sclerosus? I don't know. No.
Morphia with features of lichen sclerosus. So sometimes you'll see this, and you biopsy it, and they've got some deeper sclerosis also, so they get morphia deep and LSNA superficially. Still treat it like LSNA you want to, but they may not respond quite as well because it's got the deeper component as well. Of course, when it occurs in a male on the penile area, call it BXO. So those are some other things that are all in the same family of this. Chronic graft-versus-host disease in the differential, but usually that doesn't just give you papillary dermal sclerosis. All right.
All right, so we have a shave biopsy here. We have this trabecular pattern of, I guess I'll call it like an infiltrate coming off the epidermis.
Yeah, it's reticulated. Yeah, you're exactly right. And it's is this an inflammatory or neoplastic?
Neoplastic.
Neoplastic, which is good. What kind of differentiation?
I believe follicular.
It is follicular. Good.
So lots of few little cysts and kind of fronding, and some of it looks like it's trying to recreate some follicles there.
Yeah, these are kind of forming the. What stage, what area of the follicle do you think these are recapitulating?
The
Teensy tiny hair shaft and.
like the inner or the follicular like infundibulum.
Yeah, it's probably just beneath the infundibulum in the so-called mantle zone. That's kind of a little stem cell area. So, when the hair follicles undergo cycling, they kind of shrink up and they kind of end up at that site, and then those stem cells that are at that mantle zone sort of repopulate the lower inferior portion of the follicle, and it grows down that little fibrous sheath, and then you get a new hair follicle. So sometimes you get neoplasms that form in that area. So this is a neoplasm, these little primitive follicular structures that most likely normally reside in the mantle zone area. So you think this is benign or malignant?
I think it's benign.
Yeah, I do too. Although it's called a malignancy because occasionally these guys will develop true little basal cell carcinomas within them, or people think they're basal cell carcinomas.
Yeah.
What's the diagnosis?
It's a tumor of follicular infundibulum or pincus.
Yes. So which of those two do you like better here?
Well, I was leaning toward TFI because I thought it was more plate-like, but I guess what you were saying before, maybe it's more pincus.
Yeah, it extends a little bit more deeply. Usually TFI kind of is around this area. So when they kind of get these large nodular reticulated aggregations go down deep, and they get more basaloid areas, and some of that favors pincus. But you're right. Now, and some people think these kind of are sort of analogous to basal cells. They usually get re-excised, but they're totally, I think they behave in a very indolent fashion. They usually come as skin-colored papules, usually on the back. They don't look cancerous. They get biopsied and they get diagnosed, and people excise them.
So you don't expect to see clefting, some other,
Usually not, although sometimes you do. And
I was looking for that.
yeah, it wasn't here.
Yeah.
Sometimes you do see it. Now there's one other item. You're right. TFI is one of the items of differential. If you just had something like this only that was kind of very superficial, you might call it that. But there's one other item in the differential that can look a lot like this, but they're not really follicles. And you kind of start looking, you see there's more ductal differentiation. It kind of looks more. So what is that entity?
So maybe like hydracanthoma simplex. It's more at the top, or like a dermal duct somewhere in that.
Well, in that general family, but when you get this sort of reticulated, diffuse proliferation, and it's more eccrine syringomatous. So this is fibroepithelial. So here's the fibrous stroma tumor of pincus.
Syringofibroadenoma.
Yeah, good. So you get the syringomatous proliferation with the fibromatous component. That's syringofibroadenoma. So that's another entity of differential diagnosis. So this is a clinical of pincus like that. It's a pretty good example of that. What does syringofibroadenoma look like?
They're very, very small and skin colored.
They can look sort of like this. There's one other setting where you can see kind of a syringofibroadenomatous proliferation, sometimes in patients that have like lots of stasis alteration, lymphedema can give you that pattern on some cases. There's a syndrome that can be associated with syringofibroadenomatous proliferation. Yeah, it's not that one. It's Schultz-Schott-Passarge syndrome, and it is one of the ectodermal hydrotic ectodermal dysplasia syndromes, and they get like, it looks like a keratoderma. They get palmoplantar erythema, and you biopsy it and shows syringofibroadenomatous change. Now, could you treat this lesion with D and C?
Goes down pretty deep, but typically you can E and see anything if you go down deep enough.
Well, the main reason you probably wouldn't want to D and C this is because of the fibromatous component. Usually D and C of a basal cell, like you don't really like D and C kind of diffuse sclerosing morpheoform basal cell. If it's got this kind of fibromatous stroma like this, it's going to be much harder to wipe out these kind of aggregations down here. So if the guy actually did have a little basal cell carcinoma and you wanted to treat this, it's far better when you get this fibromatous component to do an excision of it. So these really best treated with surgical excision rather than destruction, if you're going to treat them at all. And most people do treat them, so. Okay.
So, let's look at,
Yeah, that's probably a better one right there. All right, so what kind of biopsy are we looking at?
small shave, but it's just.
Yeah, there's no epidermis, is there?
Yeah.
So there's kind of 3 types, there's really 4 types, 5 types of biopsies, but the 2 most common are shave and punch, and then excision. Some people do incision, it's relatively uncommon, sometimes you do that. And then if you're in the clinic and somebody's got a little knot on their scalp, and you just do a little nick over the top and you kind of press on it, it pops out. What's that called?
An extraction.
Or enucleation. Enucleation. So those are the main types of skin biopsies dermatologists do. So there's no epidermis here, so maybe this just kind of popped out.
Yeah.
Okay, so what are we looking at here?
Well, cyst.
A
Some sort.
cyst. Good, a cyst. Now, once you've got into the category of cyst, then you have to say, well, what kind of cyst is it? And how do we diagnose cysts? How do we name cysts?
Just by the lining.
Yeah, by the lining. Excellent.
Yeah.
So, what is the diagnosis of this cyst?
Steatocystoma.
Steatocystoma. Good. So why is it steatocystoma? There's 2 reasons. There's the obvious reason that third graders should know.
Every small child knows a sharp cuticle.
So what's the obvious reason that I'm pointing at right there?
Is that the steato part?
Well, there's sebaceous gland in the lining.
Mm-hmm.
So that's the one reason. But what's the other reason that this is a steatocystoma? The more, resident level reason.
The cuticle.
Yeah. And what's the cuticle look like in steatocystoma?
Some say shark tooth.
Yeah, good. Corrugated. It's got kind of a very special kind of cornified material. It's got this pink, this is, keratin here, but it's got this kind of corrugated pink lining. Doesn't really have much of a granular cell layer. So if you see that coupled with sebaceous glands in the wall, you've got a definitive diagnosis of steatocystoma. What are the 2 settings of steatocystoma? Sometimes the easiest questions are kind of baffle you because you're thinking of what's the genetics of this thing he's asking me about, all this kind of.
3 dermatologists' name on this one.
I'm not even going that far.
Oh.
What are the 2 main types that, again, a third grader would know?
Like normal scalp.
Just single and
Yeah, simplex or multiplex. So you get a single solitary steatocystoma, or you get multiple lesions. Now, what's kind of interesting about the multiple lesions? What's kind of the board question of the multiple lesions that they might ask? So they might show you this, expect to get diagnosed pretty quick, and then say something about it might be associated with a certain disease or syndrome. Or heredity. So if it's multiple,
Sure.
they're often autosomal dominant. So it's often hereditary usually. Yeah, so here's what they often look like. Now if you cut into one of these, what comes out?
Like a greasy fluid.
Yeah, oil.
Sebaceous and
Yeah, oil. It's not like ugly, nasty smelling rancid cheese of like an infundibular cyst. This is like an oily product. So it's a different kind of material that comes out here. And it's associated with pachyonychia congenita. Okay, so you need to know that. The boards love to ask those kind of questions, so go ahead and learn it now. Type 2 form, and it is associated with autosomal dominant. There's this mutation in KRT17, so all that's in there for you to remember. All that useful knowledge for the future. So, okay. And then, of course, the differential or other cysts. We won't talk about all those today, but we will show you some other cysts as time goes on. Oh boy, isn't this a beautiful example of this?
Okay, so we kind of see this like sweet shave or vascularization.
Yeah, or maybe even like an excisional biopsy. It could be if it's a punch, it's like about an 8 mm punch.
And so it's kind of well circumscribed, like grayish blue, kind of nodule or nodules,
Good,
kind of in the deep dermis,
excellent. Benign or malignant?
benign.
Epithelial or non-epithelial?
Non-epithelial.
Good, non-epithelial. Does it kind of remind you of anything we've seen today already a little bit?
And a little bit of kind of the like fibromatosis.
Yeah, good. It's got the
Family.
same kind of spindle-shaped cells in these areas over here.
See some staghorn vessels.
Yeah, now that's an interesting finding too, isn't it? Yeah, good eye there. So you picked up on this sort of change also at the periphery, which is interesting. So how do you sort of wed this with this?
So that maybe like the adult myofibroma.
Yeah,
Sometimes it can kind of look like a hemangiopericytoma.
good. They have, it's kind of a combination of myofibroma, myopericytoma. So that's very good. So these are myofibroblasts, just like the fibromatosis we saw earlier, is myofibroblasts. This thing's a little bit of a different animal because it's also got the vascular component to it. Sometimes you get lots of this and a little bit of this. Sometimes you get lots of this and very little of this. Sometimes you get kind of a nice mixture of both like we see in this case. So what do these things look like clinically? And why'd you say adult type?
Because you can have the infantile as well.
It could be an infantile form too. We don't know for sure just looking at this. I don't know if this is a juvenile form or an adult type. Doesn't have much sun damage, so if it's a juvenile type, adult type, they hadn't been outside yet much. So that's good. So these myofibromas like this, they commonly give you this kind of bluish gray mucinous stroma within them. And if you stained this, what would it stain for?
Like SMA.
Yeah, smooth muscle actin. Some people think that maybe the myofibroblasts, that the myoepithelial cells are associated with the vessels or the cells that may give rise to this. Because there's like a little vessel and then this thing is kind of adjacent to it. So that may be what leads to these things. But they're very interesting. And sometimes they can be multiple, sometimes they can be single. When they're in adults, they're usually solitary. When they're kids, they can be multiple. Usually not painful, but sometimes they can be if they contract, like leiomyomas. They can sometimes be a little painful. So you don't have to remove them. Conservative excision. They usually almost never turn malignant. So very nice example of that. So that's great that you're able to nail that diagnosis so quickly. Okay, a little different animal here.
This is an interesting punch. I don't know if it's
Well,
like
when
Siamese
it's this
twins,
big,
or there's like an ulceration.
yeah, it might even be like an excision or debridement or something like that. So this surgeon might have done this.
Okay, so what's striking about this biopsy is that there's this inflammatory infiltrate that's within the sub-Q. So we're kind of going in the paniculitis differential for this.
Yeah. What's going on up here?
There's like necrosis or loss of epidermis for some reason.
Yeah, so there's an ulcer. And it looks like it's pretty much sort of punched out.
Mm-hmm.
So when you see that, you say, wow, that might be outside in. Most sort of localized ulcers like this don't happen from an endogenous source. So there's a lot of vascular compromise over here. It probably would necrose everything. It doesn't just kind of give you a little localized, well demarcated, punched out ulcer.
Mm-hmm. And you can see that there's areas of the infiltrate that's darker, lighter. So it tells you that it's probably a mixed infiltrate.
Yeah, it is a mixed infiltrate.
And there's areas of necrosis too. So
Yeah. What's necrotic?
it looks like the lobules.
Yeah, the fat's necrotic. It's kind of hyalinized. What kind of cells are in here?
Septum. There's neutrophils.
Yeah, lots of neutrophils. So
Probably some histiocytes in there.
yeah, there are probably a few histiocytes, but it looks mostly like it's kind of neutrophilic,
Mm-hmm.
acute necrosis.
Mm-hmm.
What about these blood vessels?
There's fibrin and they
Yeah,
look sick.
good. Yeah, they do look sick. Fibrin in the wall, that blood vessel, they're all thrombosed here.
Mm-hmm.
Okay, and there's all these polys. So we think this is a leukocytoclastic vasculitis?
I'm leaning more towards infections, but it could be just because, fibrin plus
So there is a vasculitis here.
Kerorexis, but then the cause is...
And there's really not that much Kerorexis, though, is there? Most of these are intact neutrophils. So you've got all these blood vessels, fibrin, thrombosis, intact neutrophils, degeneration of fat, superficial, well, sort of punched out ulcer. Okay, and you said infectious. Which infection were you thinking about here?
A bacterial infection.
Okay, which one?
It's neutrophilic. Maybe. It could be. It's not. It could be staph or strep.
Yeah, there
Common
probably are
things.
some bacteria sitting in here,
Being common.
looks like. So, I don't know if those are really real or if they're
They look kind of like cocci
part of this process or not.
or rods.
They do look like they may be fungi or something. I'm not sure those things are totally real. They are real, but whether they're really part of the process or not is kind of up in the air.
But it seems like, infectious things can cause ulcers, and a vasculitis with it.
They can. You're
But
right.
also, LCV causes ulcers, and clinically we suspect LCV whenever we see ulcers. So.
Yeah, although this isn't really good for LCV, is it?
Mm-hmm.
It's a deep ulcerative process with a sharp punched out ulceration and probably got some secondary bacterial, maybe fungal contamination in it. So when it seems like it's something outside in, what do you think about?
Commonly infection or bites.
Yeah, maybe some kind of an exogenous thing like an insect bite or arthropod assault reaction. So what kind of arthropod would give you something like this?
It's pretty necrotic. So
Yes.
maybe like a brown or blue.
Yeah, something like a spider. Yeah, good. That's exactly right. So we thought I think the history was pretty good for this being a spider bite. It's a known spider bite. It gives you all this necrosis, and the spider basically injects you with chemicals that cause all of this necrosis, degeneration. It causes vasculitis. Okay, and this thing probably was an open wound and may have gotten secondarily contaminated and infected. I don't know whatever happened to this patient. It'd be kind of interesting to find out. But nevertheless, I think this was a spider bite in this case with all this suppuration and secondary necrosis and degeneration of collagen. So this is not like a mosquito bite or an ant sting. This is a pretty nasty looking situation here. Suppuration, fat degeneration. A lot of that is probably secondary. So in other words, the spider kills your fat and then it comes in and the secondary inflammation comes in. So anyway, this was generally spider bites. Every single bite or ulcer, according to patients, are caused by spider bites. So that's very maligned.
Unless they bring it in a bag.
Yeah, it never is, but they always think it is. Okay, who wants to give this one a go?
Alright, so you've got a punch biopsy. The epidermis looks acanthotic, pretty regular.
Yes, very regular.
The stratum corneum, there's whether it's parakeratosis or something.
Yeah, there's parakeratosis. It contains neutrophils. What about the granular cell layer here?
It's nearly absent.
It's gone. Good. But there's also inflammation, and then over here there's some spongiosis. So what are you thinking about here?
It looks very psoriasis form.
Yes.
Got the increased superficial dermal vasculature.
Thin suprapapillary plates. So what's the diagnosis?
Psoriasis.
Yeah. But is there anything unusual about this?
It's the spongitis.
Yeah, there's quite a bit of spongiosis. It doesn't have the nice mounds of parakeratosis with neutrophils. It's got a pretty dense inflammatory infiltrate. So it's probably psoriasis for all the reasons you said, but it's probably psoriasis that's got some superimposed inflammatory change and spongiosis. So clinically, it probably didn't look like classic psoriasis, and that's why they biopsied it. So sometimes you have to use the overall architectural features. Here's a suprabasilar mitosis. That's also helpful when you're dealing with psoriasis and with spongiosis. And so most clinicians don't biopsy classic perfect examples of psoriasis. They can usually tell from across the room. They biopsy weird lesions like this, and they want us to kind of help them distinguish between the two. And that's the best way to do it, is to use the architectural features, look for superbasilar mitoses, but sometimes there's some conflicting criteria if there's a lot of secondary inflammatory changes in it. So this was psoriasis that had spongiotic dermatitis with it. If you see biologic psoriasis dermatitis, sometimes it kind of looks like this too. It's usually a little bit more blunted without the prominent psoriasis dermatitis. Okay, who wants to give this one a go?
So this is a punch biopsy. The process is primarily in the dermis, and there was an inflammatory infiltrate. I noted that there was a lot around the vessels, and then I think there was some interface too. I'm not seeing it right now. And the other things that I noted were some mucin in between the strand of collagen, and yes, there's not too much interface.
You said mucin. There's a little bit here. I'll agree with that. But what about this?
Yeah, that's not mucin.
No?
Well, it could be. It's kind of. Where is it? It's within the epidermis, or is that surrounding?
What is this structure here?
I look probably a hair follicle.
It is a follicle. And there's some mucin kind of in the stroma surrounding it here, but also if you look inside the epithelium,
Yeah, it's in there.
or between the epithelial cells here. So what do we call that?
Like follicular mucinosis.
Follicular mucinosis. And what are the settings where you can see that?
You can see it in lupus, I think.
What are the two main settings where we see follicular mucin?
I'm not quite sure.
What if someone has a widespread eruption of patches and plaques of portoderma and
Like
probably the waistband area, and then you look at them, they got these follicular spiny lesions, you biopsy, and it shows these changes.
MF?
Yeah, mycosis fungoides. And what if it's a solitary plaque on the cheek of a 10-year-old girl and boggy, and everybody thinks it's tinea, and you take a biopsy and it shows this change?
Just focal mucinosis.
Yeah, alopecia mucinosa, the benign form. So those are the two most common settings. You can see it as a reaction pattern in other things, occasionally atopic dermatitis, rosacea. Less common with lupus to actually get it in the follicle itself.
Okay.
The mucin in lupus is here,
Yeah.
as opposed to here. Is this is a tiny amount of normal amount of mucin here. Is that the same chemical material as this? So if we extracted this and did
I would say probably not.
Yeah, of course not. Whenever I ask the question that way, right? So what is the difference between these two mucins? What is this one called?
I'm not sure.
Okay, anybody know? This is cyalo or epithelial mucin. It's sort of analogous to the mucin that gets produced in your glandular epithelium, your GI tract, salivary glands. And this is hyaluronic acid. This is what we like to inject for wrinkles. You don't inject this for wrinkles. This. It looks the same, but it's a slightly different chemical compound. This is more acidic. It's got a lower pH than this does. They used to ask on the boards back in the 60s and 70s. I think they've finally gotten away from that since Jim Graham passed away a few years ago. But the AFIP used to love to ask those kind of questions. So it's sort of stupid, but at least you know that there's a different substance there. And just know where you can see follicular mucinosis, both in a neoplastic as well as a benign setting. So these are the two situations here. Okay, good. All right. Let's
Alright.
try this one.
We have small biopsy, lots of crust, kind of serum crust at the top, and then a lot of inflammatory infiltrate in the dermis.
Yeah, what part of the body do you think you might be from?
Large hair follicle, there's maybe scalp.
Yeah, it's not really deeply rooted in the fat, though, is it? There's a couple of little sebaceous glands here, and they're not giant.
So maybe just in the face.
Yeah, face. And it's pretty dense inflammatory infiltrate. A lot of scale crust on the surface.
I think there was, well, mostly lymphocytes, lots of hemorrhage, extravasated reds, kind of tracking in and around the hair follicles and glands there.
Yeah, mostly lymphocytes. It's both perifollicular and perivascular. Okay. These large sebaceous lobules. And I don't know if one of the other cuts, this one just has one cut on it, maybe had some demodectic mites in there also.
Yeah, well, maybe this is like, well, that goes with rosacea, but
Yeah.
you know, this is just like a blown follicle or kind of
Good.
folliculitis type.
Yeah, and you know, but notice it doesn't really have a lot of suppuration in here. It's got a lot of scale crust. But this is what gets biopsied a lot of times in people that come with this erythematous eruption on the face. Biopsy shows this kind of change. It's got a lot of lymphocytes in it. It's got probably some overlying irritant dermatitis, maybe some sebderm in the background, because that kind of goes along with rosacea a lot of times. And everybody thinks it might be lupus clinically, and biopsy looks like this. So this is what we see when we biopsy some of these rosacea-like dermatitis. They look kind of like a really dense lymphocytic infiltrate, often with some scale crust, but not always. And you have to just realize that it gives you a lymphocytic infiltrate sometimes, and that's in the rosacea family. It's not lupus. So if it gets called lupus, patients walk around with the diagnosis of lupus for the rest of their life. So you don't overcall rosacea as lupus. So these are, and if you biopsy, this is kind of what it looks like sometimes. And everybody says, oh, that stuff on the left, that could be lupus. Well, notice that it's got some little papules and maybe even a pustule or two. So don't overcall rosacea as LE. Okay. You would never do that, I know. So. Okay. Okay, what do we got here? It's a nice example of this.
This looks like tiny punch.
Tiny punch. Small punch goes with fat. Any clue as to the age of the patient?
Young.
Yeah, probably a child, maybe even a baby. And what's the pattern here?
Seems to be a superficial.
Yeah, superficial perivascular infiltrate. And can you tell what kind of cells they are?
I cannot, but they.
Can you tell what kind of cells they're not?
not lymphs.
Good, because they're not dark enough. So something's different.
Yeah.
They're mononuclear cells. They're probably not lymphocytes. So that's going to be helpful as we go to higher magnification. So let's see what kind of cells we think they are. Now,
Mast cells.
yeah, good. Mast cells, lots of granules, look like fried eggs and hot dogs. What's going on over here?
Looks like collect.
Well,
Is that
forget that.
fluffy?
That's just artifact.
Okay,
But,
that's okay.
what are these cells? These red ones here.
Some decent.
Eos, yeah. So the mast cells degranulated, and they brought in some eosinophils pretty quickly. Usually within about 5 seconds they come in. So what's the diagnosis?
Cutaneous mast cell.
Yeah, cutaneous mast cell disease. It might be urticaria pigmentosa. It's probably not a large mastocytoma. Those are usually very dense diffuse infiltrations, lots of mast cells in them. It's got quite a few mast cells here. I don't think that'd be like, let's see how many Derriere signs we can elicit on this patient. You might put them in an anaphylactic shock, so be careful of that. And so this is what these look like. Obviously, there's a lot of different clinical manifestations of urticaria pigmentosa and mastocytosis. This would be more of the UP type here. So this is what these cells look like. So that's great that you're able to pick that up. So the c-KIT mutation, make sure you know about that. Make sure you know about which kind of stains you could use. The best stain is just H&E like that. So you don't need a special stain in that case. All right, we got 2 more to do. Both good cases.
Okay. So here's the excision, kind of large.
Yeah, or maybe like we had before, another one of these enucleations.
Mhm.
Good.
And can we see this large kind of tumor made up of nodules, varying sizes?
Good.
And
Epithelial or non-epithelial?
epithelial.
Good. Benign or malignant?
Benign.
Good.
You see this large calcium.
Dystrophic calcification in the center of it.
And so, seems to be multiple of them, so kind of like mama and her babies are rows and scrolls, the book calls it. I was thinking like proliferating pylosis.
Good. Proliferating tricholimal cyst or tricholimal tumor. And these can be very large. So sometimes, we talk about relatively small lesions favoring benign. Well, sometimes occasionally get large lesions that are benign. You get giant lipomas and things like that. They're still benign. So this is a large benign epithelial neoplasm. And the other thing you do when you get something that's really large is look at the individual aggregations. Individually, let's pretend like this is the whole thing. Well, this little thing is small, symmetrical, and well circumscribed. Doesn't have any mitotic figures. So it's like you take individual aggregations and put them together, and lo and behold, you get a benign process comprised of multiple little small benign aggregations. Now, these can sometimes undergo malignant degeneration. Pretty rare, but they can. So if you look through one of these and you see an area where there's lots of atypia, one of those little aggregations like this is asymmetrical and it's got a lot of mitotic figures, it may be degenerating into a cancer. So we know that these adnexal neoplasms sometimes can gradually turn cancerous. Rare, but they can. So you want to follow these patients. They don't always have to be re-excised. You don't necessarily need to remove that, but if you don't remove it and it stays there just forever, it can eventually turn cancer in some cases. Okay, last one. It's a beautiful, fantastic example of this.
Yeah, it's a punch biopsy. It looks square or rectangular in this case. And you can see from here that really the collagen is just filling up the entire space. Like I can't even see the subcube. And then you can see that there's perivascular, periadnexal lymphocytes.
Are they all lymphocytes?
It might be really mixed, but it looks pretty blue from here.
But when you see, what's the pathologic process here?
There's the collagens. Really
Yeah,
good.
so what do we call that pathologic process?
Like a sclerotic.
Sclerosis. Thickened hyalinized collagen bundles, increased collagen bundles, hyalinized, and a decrease in fibroblasts. And you said it, that the other type of cell that loves to go along with sclerotic collagen
Plasma.
is a plasma cell, yeah. And I personally think there's probably some pathophysiologic reason for that. I don't think that's just for fun. I don't think we haven't figured it out. I think if somehow we do figure out why these are here, we maybe can treat this in some way. I think that somehow that's related. Every single sclerotic condition in the skin has some plasma cells in it at some point. NLD, sclerotic DVHD, sclerotic PCT, sclerodermatomyositis. So they all have plasma cells, at least a few of them somewhere. So and a lot of times quite a few. So there's something going on here that likes sclerotic collagen, and we need a molecular pathologist, biologist to figure it out. That's probably more important than blasting somebody with Naraban, or UVA1. So this is morphia. It's got maybe a tiny little bit of LSNA up here, but the vast, vast majority of this is classic, beautiful example of morphia. And of course, here's some of the clinical photos. What's a clinical differential of this? So you're looking at a picture, especially the back lesion. What else can do this clinically? It comes in that way all the time.
It's hyperpigmented.
Well, it's asymmetrical. It's pretty broad. It looks like patches and plaques. So what else can look like this?
MF.
Good, MF. We see that missed a lot. And again, it's rule out MF and it's morphia. So widespread morphia or scleroderma can look like mycosis fungoides clinically sometimes. So stuff on the right, it's got that more LSNA, sort of white ivory appearance. You wouldn't really leave it there. And if you felt it clinically, it's sclerotic, you wouldn't think of that. But looking at it from a histologist clinical photograph, teledermatology, you might think of MF. So you got to have other features to define that. Obviously, the biopsy help. These two slides. I mean, it's pretty straightforward. Last case for you guys. Okay, any questions?
Thank you very much.
Thank you.
You're welcome.